Thank you. First of all, I would like to express my sincere gratitude to GART for giving me this opportunity. So we will start our presentation. My name OARs, organs at risk, and target volume concepts. Learning objects. After this presentation, participants will able to define target volumes and OARs. Describe GTV, CTV, ITV, and PTV. Identify common OARs in our routine radiotherapy practices. Introduction. What is our radiotherapy goals? Everyone know our goal is deliver adequate dose to tumor, minimize dose to normal tissues, and achieve maximum tumor control. Reduce treatment related toxicity also. It's for successful treatment is equal to tumor coverage plus normal tissue sparing. Why target volume delineation? What was the importance of the target volume delineation? First point is ensure accurate treatment delivery. Everyone know our goal is the proper treatment. We need to treat patient properly. That's why the first point is ensure accurate treatment. Reduce geographic miss. In radiotherapy, geographical miss occurs when the actual delivered radiation beam fails to completely cover the intended target. That means geographical miss. In the our second point is reduce the geographical miss. Third one, improve local control. Fourth, reduce recurrence. And for fifth, protect critical organs. What are the challenges we are facing? Microscopic disease spread, organ motion, and setup uncertainties. First one, target volume concept. Target volume hierarchy. First thing in target volume hierarchy, first GTV, then CTV, then ITV, and last one is PTV. In radiation oncology and medical physics, target volume concept refer to a standardized framework established by ICU. This hierarchy uses expanding concentric margins around the tumor to ensure the malignancy receives an adequate radiation dose while accounting for a microscopic spread, organ motion, and positioning variations. The purpose standardize the contouring, improve the treatment accuracy, and facilitate communication among between the professionals. First, we will discuss about GTV. What's the definition of GTV? Visible, it is the visible and measurable or palpable extent of the cancer. In simple terms, it is the actual tumor mass that a doctor can physically feel during an exam or clearly seen on imaging scans like CT, MRI, or PET scans. It includes primary tumor, GTVP, the main measurable mass of cancer tissue, that is primary tumor. Then lymph nodes, involved lymph nodes, any regional lymph nodes that are visibly enlarged on a CT or MRI and PET scan. That's primary tumor. Then last thing, metastatic lesion, GTVM, any distinct secondary tumors in other organs that are being specifically targeted. The GTV includes the entirety of the visible masses, which means it also includes any dead cancer cells, fluid-filled spaces, or area of lacking oxygens that are trapped inside the borders of the visible tumors. Now we are discussing about what are the GTV include. Next, we will discussing what the GTV strictly excludes us. To truly understand what the GTV includes, it is helpful to know what the doctors purposefully leave out of it. First thing, microscopical spread. Second, internal motion. Third, patient positioning errors. The GTV does not include the surrounding healthy looking tissue that might be harbor invisible and microscopic cancer cells. and does not include account for the tumor moving when the patient breathes or digests, and also not include safety margin for millimeter level shift how to the patient lies on the table. Next, clinical target volume, CTV. The definition is CTV is equal to GTV plus area of potential microscopic diseases, because the microscopic cancer cells are too small to appear on any CT, MRI, or PET scan. The CTV cannot be seen instantly. Radiation oncologists must deduce where it is using medical knowledge and anatomy. They determine the CTV based on three main factors: standard expansion margin, natural anatomical barriers, and high risk lymph nodes. Standard expansion margin based on a decade of pathology data, doctors know how far certain cancers typically spread microscopically. For example, they might automatically add 1 centimeter border around the GTV for a specific type of lung cancers. Natural anatomical barriers. Cancer does not spread equally in all directions. It it struggle to cross a dense tissues like bone, cartilage, or a thick muscles. If a tumor resting against a bone, the doctor will crop the CTV margin so doesn't exceed into a bone, knowing the cancer likely stopped there. Next, high risk lymph node. If a specific type of cancer is highly likely to travel to nearby lymph nodes, doctor will include these normal looking nodes in CTV just to be a just to be safe. This practice called elective nodal irradiation. The formula of CTV is equal to GTV plus microscopic disease margin. We will discuss about the CTV examples. In head and neck cases, peritoneal spread and high risk nodal regions, a margin is added across the gross tumor volume to account for microscopic infiltration into adjacent soft tissue and muscles. Normally, it is around 5 to 10 mm. Include elective irradiation of specific cervical nodes levels. In prostate, we will include prostate glands and seminal vesicles. The CTV always include the entire prostate glands depending on the patient risk groups. The proximal or entire seminal vesicles are included if there is a significant risk of micro-invention. In brain tumors, example high-grade gliomas or glioblastoma, edema and infiltrative margin, the grade brain tumors characteristically invade along white matter tract beyond the visible contrast. Enhancing tumor or on MRI, the CTV includes the peritumoral T2 flare hyperdensity edema plus an extra margin, often it is around 1.5 to 2 centimeter, to cover the infiltrative tumor cells. Next, internal target volume ITV. What is the definition? CTV plus internal motion margins. The common sites are lung, liver, pancreas. In it is a CTV plus an extra safety margin to account for internal organ movements. While the CTV maps out of the biological shape of the cancer, the ITV maps out of the physical space the cancer occupies as it moves around inside the living body. Tumors are not perfectly still, they shift, slide, and bounce based on a natural involuntary bodily functions. Why we do need an ITV? Without an ITV, radiation beam targeted perfectly at the resting tumor would result in a geographical miss the second patient took a deep breath. Doctors use the ITV protect against three main type of internal movements: respiratory motions, organ filling, and physiological motions. What is respiratory motions? In the example, the lung, liver, and esophageal tumors are moved continuously up, down, and sideways as a patient breathes or a breathes. A lung tumor can shift by more than 1 to 2 centimeter during a single deep breath. Sorry. Organ filling. Pelvic tumors, example, pelvic tumors, shift based tumors are shift based on a what happening around them. A prostate tumor can push it in different directions depending on how full the patient's bladder is or what whether there is any gas stool in the rectum. Physiological motion, involuntary actions like the heart breathing, swallowing, or stomach digesting food cause suitable shifting nearby tissues. ITV determinations, we are using techniques 4DCT, respiratory gating, breath hold, and MIP reconstructions. How do doctors create the ITV? To map out the ITV, doctors need to capture the tumor in action. For lung cancers, in example, for lung cancers, they often use 4D scan, unlike standard static 3D scan. 4D scan records the patient breathing cycle over time. It takes a series of rapid images, allowing the oncologist to see the exact path the tumor travels from the top of the inhalation to the bottom of the exhalation. The doctor then blends these images together to create the ITV and envelop that the safety enclosure the entire path of the moving tumor. MIP. What is MIP? Maximum intensity projection. Clinicians often combine the CT phases using a computational tool called a MIP image because high density tumor tissues contrast with low density lung tissue. The MIP displays the highest pixel value across all respiratory facing single 3D image, effectively creating a 3D composite of the tumor trajectory. Next, the PTV. What is PTV? The planning target volume is a geometrical concept in a radiotherapy. It is called PTV. It is the final outermost volume mapped by the clinical team. The PTV represents the entire treatment zone that is in a linear accelerator is programmed to hit. The definition of PTV, CTV or ITV plus setup margin. It is accounts for patient position errors, machine uncertainties, immobilization variation. Setup uncertainties. A patient comes in for a treatment 5 days a week for a several weeks. Even the laser alignments and systems and the custom modules, the patient might lie down slightly twisted or shifted by 2 to 3 millimeters from one day to next day. This is setup uncertainties. Then mechanical inaccuracy. We know the radiation machine is a massive piece of heavy machinery that rotated around the patient over time. There can be minute millimeter level deviation in the mechanical alignment of the beam. This is called mechanical inaccuracies. And patient movements. A PTV might twitch solo or slightly shift their weight while lying on the heart treatment table during actual minutes to the being active. These are including in our PTV. Why PTV margins are used? Even with the precise immobilization, small variation occur during treatment. The PTV accounts for systematic errors. What systematic error is? Daily positioning inaccuracies or calibration offsets. Random errors. The random errors means patient shift, anatomical changes, or day-to-day organ motions, and mechanical tolerances. What is systematic error and random error? Systematic error, reproducible error, and present throughout the treatment. Random error, the daily variation changes fraction to fraction. In example, Systematic error happens during the treatment planning phases because it happens at every beginning. It get bugged into the entire treatment plan and repeat itself every single day. I will give you some example to easily you can understand. You are shooting in arrow, but the sight of your bow is slightly misaligned 2 inches to the left. Every single time you shoot perfectly, this arrow will still land 2 inches to the left because already the arrow, your sight of the bow is misaligned by 2 inches. This is systematic error. In clinical, we are saying as example during the initial setup scan or the patient hold their breath slightly different or the treatment lasers are miscalibrated by 2 millimeters because the entire 6 week treatment plan is built on this scan and the radiation beam will be off by 2 millimeters in every single day. This is called systematic error. In random error, day by day fluctuations that changes unpredictably from the treatment sections to the next. The same we will discuss same example. Your boy's sight is perfectly fine, but first day your handshake slightly. That time the you miss the target. Next day you are perfectly shoots that time that here arrow hit the target properly. This is random error. In clinically on Monday the patient lies slightly down or twisted. On Tuesday there your positioning is perfect, but Thursday the bladder full and the pushing the tumor upwards. This is called a random error. Then we will discuss about Van Her formula. The Van Her margin formula is a radiotherapy planning standard to using to calculate the expansion from a clinical target volume to a planning target volume. The Van Her formula developed by Marcel Van Her and published in 2000. It's an industry standard mathematical recipe to use the radiation oncology to calculate the PTV margin needed around the target. The primary purpose to ensure that the 99% of patients receive at least 95 of the prescribed radiation dose to the clinical target volume, accounting for geometrical uncertainties during treatment. The formula is equal to M is equal to 2.5 capital sigma plus 0.7 lowercase sigma. M requires PTV margins, that is in millimeters, and capital sigma standard deviation of systematic errors, and lowercase sigma is equal to standard deviation of random errors. In to use the formula correctly, medical physicists divide treatment uncertainties into two distinct categories. In this diagram, you can see the illustrated of the evolution of ICRU target volume definitions. In this radiation therapy across three stages A, B, C, it shows how the target volume expanded over the time to account for the microscopic disease, positioning uncertainties, and internal organ moves. In picture A, what it shows a generic target volume enclosed directly inside the treatment volume, light that is in light blue rectangle, and the irradiated volume outer green shade. In pic B, what is shows the expansion from GTV, CTV, and PTV. Gross tumor volume you can see at red, and that is actual visible or palpable tumor. Next CTV, the pink color one, that is GTV plus a margin for invisible, subclinical, and microscopic disease spread. Next one, PTV, the blue color one. That is CTV plus a safety margin to account for both daily patient setup errors and organ motion internal margins. Diagram C, what it shows the addition of the ITV, internal target volume, in between CTV and PTV. That you can see in yellow color. Internal margin accounts specifically for an internal organ movement size and shape changes over the time. PTV is equal to ITV plus a set of margin. The outer blue envelope added to the ITV to account the purely for daily positioning uncertainties, machine alignment, and laser shift. Next, planning risk volume PRV. In radiotherapy, PRV stands for planning organ at risk volume. To understand the PRV, you first have to understand OAR. OAR means organ at the risk. And OAR is healthy critical organ near the tumor that could be permanently damaged if it absorbs too much of radiation, like spinal cord, brainstem, or optic nerves. Just like the tumor moves and experiences daily setup errors, healthy organs move and experience setup errors too. The PRV is the OAR plus protective safety margin built around it. Then we will start with organs at risk. Definition you already discussed. Normal tissue whose radiation sensitivity may significantly influence the treatment planning. An OR is a healthy normal organ or tissue located close to the tumor that could be seriously damaged by the radiation beam. While the entire goal of radiotherapy is to deliver a destructive lethal dose to the tumor, and the goal is an OAR is exact opposite. Shield it as much possible. Importance of OAS: prevent toxicity, prevent organ function, improve quality of life. In medicine and oncology, toxicity refers to the harmful side effect or accidental damage caused to the healthy tissue and organs by a medical treatment. The collective importance of all these volumes, example GTV, CTV, ITV, and PR, OR, PRV, and errors, is it just an exercise in a medical vocabulary? Together, they are form the absolutely foundation of modern high precision cancer treatment. Before these international standards were created, radiation was a bit of a blunt instrument. Today, the framework allows doctors to achieve ultimate goal of radiation oncology, maximize the chance of curing cancer while minimize life-altering side effects, striking the perfect balance. Radiation is, everyone knows, radiation is a double-edged sword. If you understood the tumor, the cancer returns. If you overdose the surrounding healthy tissue, you can cause severe organ damage. By mapping the disease layer by layer, the clinical team can push radiation dose to its absolute mathematical limit. The PTV ensures that cancer is completely obliterated while the PRV acts as a hard boundary to keep critical structures safe. Then we will discuss the common OARs in head and neck radiotherapy. In head and neck radiotherapy, common OARs are spinal cord, brainstem, and parotid glands, cochlea, optic nerves, lens, and opticism. The possible toxicities are xerocytomia, hearing losses, vision loss, myelopathy. In the case of thoracic radiotherapy, the common OARs are lung, heart, esophagus, and spinal cord. The possible toxicities, radiation vulnerabilities, cardiac toxicities, esophageal myelopathy. These are the common possible toxicities. In pelvic radiotherapy, common OARs are rectum, bladder, small bowel, and femoral heads. Possible toxicities, prostatitis, cystitis, endometriosis, hip complications. Then we will discuss about DVH and dose containers. A DVH means dose volume histogram. Is the most essential graphical tool used in a radiational treatment planning to summarize the 3D radiational dose distributions into a single easy to read 2D plot. Dose containers. They are the pure defined numerical threshold used in a radiation treatment planning to limit the radiation delivered to the surrounding healthy tissue or healthy tissue while ensuring adequate tumor coverage. What are the dose constraints? During the inverse planning process, in case example the IMRT, VMAT, the optimization software release on a dose constraints as a strict mathematical boundaries or cost function targets. They dictate the upper limit of healthy tissue, the maximum radiation doses that critical organs can safely tolerate with unacceptable risk of complications. Lower limit of target volume, maximum dose required to the guaranteed tumor destruction. Example 95 of PTV must receive 100% of prescribed dose. These values are typically standard function benchmark. If hypofractionation or a stereostatic body radiation therapy, this will be different per fraction dose and concession applied. Okay, in this picture, we can see the constraint of a particular organs. Spinal cord Dmax below the 45 gray, brainstem Dmax below 54 gray, parotid in mean dose below to 60 gray. I like. In this slide, we will discuss the comparison of standard or hypofractional concerns in organs spinal cord. The standard fractions Dmax is below the 45 gray. In 5 fraction SBRT, Dmax is greater than 25.3 to 30 gray. In 3 fraction SBRT, that is 21.9 to 22.5 gray. In 1 fraction SBRT, it is 12.4 to 14 gray. That is the difference. You can add in brainstem Dmax below 54 gray in standard conventional 25 to 35 fractions. That is comes to 5 fraction SBRT. It is a different 28 to 31 gray in Dmax, and in 3 fraction it is 21.2 to 23.1 gray, and the single fraction it is below 15 gray. In parotid cases, that's in 20 D mean is equal to below 25, 26 gray. Then in this case in SBRT, D mean in PTV in 20 to 25 gray, and below to 20 to 25 gray, and D mean 15 to 18 gray below. Same in single fraction is 10 to below 10 to 20 gray. This is summary and the conclusion of this presentation. Key points: GTV, gross disease; CTV, microscopic disease coverage; ITV is equal to motion conventions; PTV, setup uncertainties and compensations; PRV is equal to organ protection margin; OAR sparing is essential for reducing toxicity; accurate countering improves treatment outcomes. Thank you. Thank you for GRT once again. Give me the such kind of good opportunities.
Hi, hi all. Good evening, all.
Good evening.
Thank you, Anoop, for the wonderful knowledge sharing.
Thank
And